You're listening to Concepts in Psychiatry, the premier podcast for psychiatrists, psychiatry residents, and other mental health professionals interested in strengthening their knowledge of the fundamental concepts of psychiatry and learning the latest news in the treatment of mental health disorders. I'm your host, Dr. Sarah De Leon, a third-year resident in psychiatry, and this is episode 10, originally airing on December 4th, 2017. Today's topic is the diagnosis and management of alcohol use disorder. Alcohol use disorder is a prevalent illness throughout the country, and it accounts for 85,000 deaths per year in the United States, with an estimated yearly cost of alcohol use disorder estimated at over $250 billion. In the United States, the 12-month prevalence of alcohol use disorder is estimated to be 4.6% in teenagers and 8.5% in adults, with the 18 to 29-year-old age group having the highest rate of 16.2%. There are a number of risk factors that can contribute to the development of alcohol use disorder. These include male gender, Native American or Alaska Native races, co-occurring conduct disorder or antisocial behavior in adolescence, a family history of alcohol use disorder or other substances, and comorbid schizophrenia or bipolar disorder. Alcohol is the third leading preventable cause of death in the United States. Most individuals who develop alcohol use disorder have a first episode of alcohol intoxication in their mid-teens, and they eventually develop full criteria for alcohol use disorder by their late 20s. The disease is characterized by a variable course with periods of remission and relapse. There are several terms that we first should define also before discussing the DSM-5 criteria for alcohol use disorder. First up is unhealthy alcohol use. This encompasses alcohol use that can cause a risk for potentially negative consequences, a use that has already resulted in negative consequences but not yet met diagnostic criteria, or a use that is accompanied by features meeting diagnostic criteria. Risky alcohol use refers to the consumption of an amount of alcohol that puts the individual at risk for health consequences. According to the National Institute on Alcohol Abuse and Alcoholism, in the United States, the following consumption amounts constitute an increased health risk to the consumer. For men under the age of 65, more than 14 drinks per week on average, or more than 4 drinks on any day. And for women or men aged over 65, more than 7 drinks per week on average, or more than 3 drinks on any day. A standard drink is considered to be 12 grams of ethanol, 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of 80 proof liquor. And the NIAAA estimates that about 28% of adults in the United States exceed the above recommended thresholds for alcohol consumption at any given time. The last term to define is binge drinking. This is defined also by the NIAAA as drinking enough alcohol within a 2-hour period that the blood alcohol content level reaches about 0.08 grams per deciliter. This is usually about 4 drinks for women and 5 drinks for men. Data from the National Epidemiological Survey on Alcohol and Related Conditions that was published in 2015 show that 14% of adults in the United States met criteria for recurrent alcohol use disorder, and that 29% had met criteria in their lifetime. The DSM-5 defines alcohol use disorder as a problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by at least 2 of the following within a 12-month period. The criteria being alcohol that is often taken in larger amounts or over a longer period than was intended, a persistent desire or unsuccessful efforts to cut down or control alcohol use, a great deal of time spent in activities that are necessary to obtain the alcohol, use the alcohol, or recover from its effects, cravings or strong desires or urges for alcohol use, recurrent alcohol use that results in a failure to fulfill major role obligations at school, work, or at home, continued alcohol use despite having persistent or recurrent social or interpersonal problems that are caused or exacerbated by the effects of alcohol, important social, occupational, or recreational activities being given up or reduced because of alcohol use, recurrent alcohol use in situations in which it is physically hazardous, alcohol use that is continued despite the knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol, tolerance as defined by a need for markedly increased amounts of alcohol to achieve intoxication, or a markedly diminished effect with continued use of the same amount of alcohol. And lastly, withdrawal, as manifested by either the characteristic withdrawal syndrome for alcohol use, or alcohol or a closely related substance such as benzodiazepines are taken to relieve or avoid withdrawal symptoms. The DSM-5 also includes several specifiers for alcohol use disorder, and these include in early remission, where the full criteria are met for alcohol use disorder, and then subsequently none of the criteria are met for at least 3 months but less than 12 months, with the exception of possible continuing cravings for the alcohol. And then in sustained remission would be when full criteria are met, and then subsequently none of the criteria are met for at least 12 months, once again with the exception of possible cravings. And then in a controlled environment, in which the individual is in an environment where alcohol access is restricted, such as a hospital or jail. The other specifier in DSM-5 for alcohol use disorder is the severity. And a mild severity would be when the patient has 2 to 3 symptoms, moderate severity is 4 to 5 symptoms, and severe is 6 or more symptoms. The pathogenesis of alcohol use disorder is currently unknown, but it is likely multifactorial, with contributing factors including genetic factors, which have been estimated to be responsible for about 50 to 60% of vulnerabilities related to alcohol use disorder, environmental influences, including intrafamilial influences, prenatal exposure, parenting patterns, and peer influence, specific personality traits, including neuroticism, impulsivity, and extroversion, and cognitive functioning, with cognitive dysfunction being potentially associated with the development of alcohol use disorder. There have also been 4 main theories that have some empirical support that may help to explain the trajectory of alcohol use disorder. The first of these theories is the positive affect regulation theory. This states that alcohol use has a direct neurochemical effect on the brain's reward centers. In other words, there is positive reinforcement with drinking behaviors. The second theory is the negative affect regulation theory, and this states that drinking is more used to relieve negative feelings in the patient, and this is also called sometimes the self-medication hypothesis. The third theory is pharmacological vulnerability, and this states that individuals differ in response to the acute and chronic effects of alcohol use, with some people being more prone to the development of alcohol-related difficulties than others. And the last theory is called deviance proneness, in which alcohol consumption is part of an overall picture of social deviance that arises in childhood and results from deficient socialization. Now we'll talk a little bit about the evaluation of alcohol use disorder. It is important to identify individuals who suffer from alcohol use disorder and also individuals who participate in heavy drinking that places them at risk for the development of alcohol use disorders. It is now recommended that all adult primary care patients be screened for unhealthy alcohol use. Some of the diagnostic tools that we have include psychiatric evaluation, including a comprehensive review of the patient's substance use, questionnaires such as the CAGE questionnaire and the Audit-C, and laboratory markers like liver enzymes, MCV, GGT, and CDT. Evaluation of potential alcohol use disorders, as well as other substance use disorders, should include a comprehensive review of the patient's current and past substance use, including amounts, frequencies, types of alcohol consumed, a review of potential diagnostic criteria for alcohol use disorder as previously discussed, a family history of any substance abuse or treatment, and any medical, psychiatric, or behavioral complications that have arisen from alcohol use in the patient's life. It is important to also gauge the functional impairments of the patient's alcohol consumption, including driving and operating machinery, school, work, interpersonal relationships, and physical health, as well as other psychosocial consequences. It's also important to evaluate for comorbid psychiatric illness, including conduct problems, depression, anxiety, and insomnia, because these can frequently accompany heavy alcohol use and many times may precede it. Antisocial personality disorder, bipolar disorder, anxiety disorders, depressive disorders, and schizophrenia are all associated with an increased rate of alcohol use disorder. In fact, about 30 to 40% of individuals with alcohol use disorder also meet the diagnostic criteria for major depressive disorder at some point in their life. Patients may have turned to alcohol to cope with their psychiatric symptoms, or their psychiatric symptoms may have developed secondary to chronic alcohol abuse and its effects on employment, family, and other psychosocial factors. These patients are also at an increased risk of suicide secondary to both acute alcohol intoxication and in the context of substance-induced mood disorders. In fact, about 15% of persons with alcohol abuse or dependence have been reported to commit suicide, a rate that is second only to those diagnosed with major depressive disorder. Patients should also be evaluated for other potential alcohol-related disorders, and some of these can include, of course, alcohol withdrawal and delirium, but also a number of other disorders. First up is alcohol-induced persisting dementia, which is a poorly studied heterogeneous long-term cognitive deficit that can develop in alcoholic patients. It involves a decrease in intellectual functioning, cognitive abilities, as well as memory. Another disorder that's possible is alcohol-induced persisting amnestic disorder, which is a disturbance in short-term memory that is caused by prolonged heavy alcohol use. This consists of both Wernicke's encephalopathy and Korsakoff syndrome, both which are caused by thiamine deficiency. Wernicke's encephalopathy is more of an acute neurological disturbance that's characterized by ataxia, vestibular dysfunction, confusion, and ocular abnormalities, while Korsakoff syndrome is a more chronic condition characterized by mostly irreversible anterograde amnesia and possibly confabulation. Other possible disorders to screen for include alcohol-induced psychotic disorder, which can occur in about 3% of alcoholic individuals and consists mainly of auditory hallucinations and paranoid delusions, and usually resolves within 1 week. Also, alcohol-induced mood disorder, which can mimic the symptoms of major depressive disorder over several weeks, and which usually rapidly improves with abstinence from alcohol. And alcohol-induced anxiety disorder, which can consist of generalized anxiety symptoms or panic symptoms, especially within the withdrawal period and the first few weeks of abstinence from alcohol. There are some other disorders to screen for as well, including alcohol-induced sexual dysfunction and alcohol-induced sleep disorder. In addition to evaluation for psychiatric illness, these patients should follow regularly with their primary care physician because repeated chronic alcohol use can affect almost every organ and system in the body. Common medical disorders seen in heavy alcohol users include gastritis, stomach or duodenal ulcers, low-grade hypertension, peripheral neuropathy, and cognitive deficits. More severe conditions associated with chronic alcohol abuse include liver cirrhosis, pancreatitis, cancers of the GI tract, including the esophagus and the stomach, cardiomyopathies, and Wernicke-Korsakoff syndrome. Some physical signs and symptoms that can be seen in chronic alcohol use disorder include nausea, dyspepsia, bloating, hepatomegaly, esophageal varices, tremor, unsteady gait, insomnia, and erectile dysfunction, among others. Providers can also look for physical features of advanced liver disease in heavy chronic drinkers, which can include spider angiomata, pulmonary erythema, hepatic enlargement, or splenic enlargement. It's of course also important to look for signs of acute withdrawal in this patient population, as patients with a history of complicated alcohol withdrawal may need to be evaluated for possible hospitalization. Withdrawal symptoms can include tremors, irritability, nausea, vomiting, sympathetic autonomic hyperactivity, anxiety, arousal, sweating, facial flushing, mydriasis, tachycardia, and hypertension. Patients could also experience seizures, alcoholic hallucinosis, and delirium tremens, and these are potentially serious and life-threatening conditions that have to be closely monitored. A future episode of this podcast will be discussing assessment and management of alcohol withdrawal specifically, so stay tuned for that discussion. And lastly, in terms of the evaluation, there are certain laboratory markers that we can look at for evaluation of a patient's alcohol use. The first is GGT, gamma-glutamyl transferase, and this is a marker that can be the only elevated marker in some patients. However, 70% of patients with elevated GGT are persistently heavy drinkers, likely 8 or more drinks per day. CDT, or carbohydrate deficient transferrin, is another potential marker. This can have even higher levels of sensitivity and specificity than GGT in identifying patients who are persistently heavy drinkers, once again indicating at least 8 or more drinks per day. The blood alcohol level, or BAL, can be used to judge tolerance to ethanol, indicating that the patient may be a heavy chronic alcohol user. In the United States, a BAL of 80 to 100 milligrams of ethanol per deciliter of blood is considered to be legally intoxicated. The MCV, or mean corpuscular volume, is another useful test that can be elevated in heavy drinkers due to direct toxic effects of alcohol on erythropoiesis. And lastly, liver function tests like AST, ALT, and alkaline phosphatase can indicate heavy chronic drinking that has led to liver damage. Now let's talk about the treatment for alcohol use disorder. There are 3 general steps that are involved in treating a patient with alcohol use disorder. These are intervention, detoxification, and rehabilitation. It's quite common for patients with alcohol use disorder to go through these steps multiple times, as the typical nature of alcohol use disorder is a relapsing and remitting disorder. The first step, intervention, involves a face-to-face discussion with the patient about the reality of their disorder. The goal is to break through the patient's feelings of denial and to help them recognize what the negative consequences of their disorder are that could happen if they do not seek treatment. Unfortunately, a single intervention is rarely sufficient for a patient to recognize the need to seek treatment. However, persistence with these interactions can eventually lead the patient to the next steps in their treatment. Family members can be a great help in this step of treatment. It is important that they recognize the need to not enable and protect the patient, because this can prevent the patient from gaining enough motivation to want to change. Detoxification can thus follow on an outpatient or inpatient basis, depending on how severe the patient's withdrawal is and whether they have any history of complicated withdrawals, such as seizures or DTs. Alcohol withdrawal is characterized by a phase of acute withdrawal symptoms following heavy and prolonged use of alcohol, which begin to develop about 4 to 12 hours after reduction of intake. Benzodiazepines are the mainstay of alcohol withdrawal treatment, and as previously mentioned, a future episode of this podcast will discuss assessment and management of alcohol withdrawal specifically. Detoxification can also include offering adequate nutrition to the patient and supplementation with thiamine. The third step, and perhaps the most challenging step for most patients, is rehabilitation. This consists of 3 main components. First of all, a continued effort to maintain motivation for abstinence on the part of the patient. Second of all, working to help the patient readjust to a lifestyle without alcohol. And third, relapse prevention. Usually about 2 to 4 weeks are needed as an intensive inpatient or outpatient period of help, followed by a 3 to 6 month period of less frequent outpatient follow-up. Outpatient care can also consist of a combination of individual counseling, group therapies, self-help groups such as Alcoholics Anonymous, and the use of psychotropic medications. In terms of the individual counseling within the first 3 to 6 months should focus on the day-to-day issues in the patient's life of maintaining motivation for sobriety, enhancing their functioning, and building a lifestyle free of alcohol. This can include learning coping strategies and techniques for dealing with social events that involve alcohol, as well as the development of a sober peer group. Relapse prevention is also a core part of the recovery process, and patients should be educated that a slip in their sobriety is not an excuse for returning to their old drinking habits. They should also be educated that slips can be an important learning process in that they allow the patient to identify high-risk situations for their alcohol use. Therapies can be carried out in either a group setting or on an individual basis. Self-help groups such as Alcoholics Anonymous have a great potential to be an important part of an alcoholic patient's recovery program. Some of the benefits of AA groups are that they give the patient a sober group to associate with. They help them learn it is possible to participate in social functions without alcohol, and the patients are able to see a model of what recovery looks like as exemplified by the other sober members of the group. Medication management can also be part of the approach to treatment. Generally speaking, symptoms of depression or anxiety that are second to alcohol use should be managed by treating the underlying condition, the alcohol use disorder, and with behavioral modifications and reassurance. Pharmacotherapy should be considered in patients with alcohol use disorder who have a moderate to severe subtype and who also have current heavy use and ongoing risk for consequences from use, are motivated to reduce their alcohol intake, prefer medication along with or instead of psychosocial interventions, and do not have any medical contraindications to the individual drug. Patients with coexisting psychiatric illness, however, should be treated with appropriate medication management. There are also some specific medications that can be used to treat alcohol use disorder. The first medication is naltrexone. Naltrexone is a mu-opioid receptor antagonist that causes reduction in cravings as well as reward in response to alcohol consumption. It can be dosed at 50 milligrams by mouth daily. Before prescribing, the physician should assess for current possible opioid use, as concurrent use with opioids can precipitate a withdrawal syndrome. Physicians should also obtain urine toxicology and liver function tests. Contraindications to use of naltrexone are concurrent opioid use, acute opioid withdrawal, an anticipated need for opioid analgesics, acute hepatitis, or hepatic failure. Common side effects to be aware of include nausea, abdominal pain, constipation, dizziness, headache, anxiety, and fatigue. Serious adverse reactions can include hepatotoxicity, but this is more commonly seen in patients who are on extremely high doses of naltrexone. Naltrexone is also available as a long-acting depot injection, which can help improve compliance and achieve a better steady state level of the drug. The only approved depot naltrexone in the US currently is Withdrawal, which can be dosed at 380 milligrams intramuscularly every 4 weeks. Another potential agent is acamprosate. This is an unknown mechanism of action at this time, although it is possible that its effect is secondary to modulation of glutamate neurotransmission at the metabotropic 5 glutamate receptors. Like naltrexone, it too decreases cravings for alcohol. This can be dosed at 666 milligrams by mouth 3 times a day, or at 333 milligrams by mouth 3 times a day in patients with impaired renal function. Contraindications to acamprosate include severe renal impairment where the creatinine clearance is less than 30 milliliters per minute. Precautions should also be taken with its use in patients with depression or suicidality. Serious side effects can include anxiety, depression with a possible suicide attempt, acute kidney failure, heart failure, mesenteric arterial occlusion, cardiomyopathy, deep thrombophlebitis, and shock. More common side effects are diarrhea, nausea, flatulence, abdominal pain, headache, back pain, infection, flu-like syndrome, chills, somnolence, decreased libido, amnesia, and confusion. Acamprosate is a good medication to consider in alcohol use disorder patients who have acute hepatitis, liver failure, or elevated liver enzymes, or those who are on concurrent treatment with opiates. A third medication is disulfiram, which is an aversive agent that acts as an inhibitor of alcohol metabolism in order to cause a buildup of acetaldehyde. This leads to an uncomfortable reaction of flushing, sweating, nausea, and tachycardia if the patient does consume any alcohol. It can be dosed at 500 milligrams by mouth daily for 1 to 2 weeks, followed by a maintenance dose of 250 milligrams by mouth daily. Some side effects to be aware of include potential for mood swings, psychosis, peripheral neuropathy, and potentially fatal hepatitis. It is important to address any hidden forms of alcohol with the patient. These can include mouthwash, tonics, hot sauces, energy drinks, or sauces cooked with alcohol in them. Patients with pre-existing heart disease, cerebral thrombosis, diabetes, and other serious medical conditions should not be given disulfiram as it can be fatal. Because patients need to stay compliant with this medication on a daily basis in order to benefit from its effects, it should be given mainly in patients who are highly motivated to stop drinking. These are the 3 first-line medications that we can use in alcohol use disorder. There are also several second-line medication options. Topiramate is not FDA approved for alcohol use disorder, but it has been shown to decrease the consumption of alcohol compared to placebo. It should be dosed at 50 milligrams by mouth daily and gradually titrated up to 150 milligrams by mouth twice a day over several weeks. Potential adverse effects include cognitive impairment, paresthesia, weight loss, headache, fatigue, dizziness, and depression. A second possible option is gabapentin. It has been supported by efficacy shown in clinical trials for DSM-4 alcohol dependence diagnosis. However, this benefit has not been definitively established in a larger sample size. Gabapentin is well tolerated at lower doses to moderate doses. However, sedation and dizziness can occur at higher doses. Gabapentin can also potentially be subject to abuse by some patients. Baclofen has been shown to have mixed results with regards to the treatment of alcohol use disorder. Preliminary trials suggested that perhaps a higher dose of baclofen, such as 60 milligrams by mouth daily, may be effective in alcohol use disorder, but this will require further randomized trials. Treatment with baclofen is well tolerated, and mild to moderate side effects include nausea, vertigo, transient sleepiness, and abdominal pain. Lastly, nalmefene is an opioid antagonist that has also been found to reduce drinking in patients with alcohol use disorder. It has several advantages over naltrexone, including the absence of dose-dependent liver toxicity, longer-acting effects, and more effective binding to central opiate receptors. However, nalmefene is not currently available in the United States. There is also, of course, the option to combine medications, particularly those with different mechanisms of actions, in some patients in order to produce a more effective response. Lastly, I want to discuss the prognosis of alcohol use disorder. About 10 to 40% of alcoholic individuals eventually enter a formal treatment program during the course of their illness. There are several signs that are good prognostic indicators in terms of treatment outcomes. These include an absence of pre-existing antisocial personality disorder, an absence of another type of substance abuse or dependence, general life stability such as a stable job, good family support, and the absence of severe legal problems, and remaining in treatment for the full course of the initial rehabilitation phase. The presence of these 4 prognostic indicators in one patient indicates about a 60% chance of abstinence for 1 or more years after completion of the program. Alcoholic patients who have comorbid mental illness should also be effectively treated for their mental illness, in the hopes that increasing stability in their lives overall can eventually help to contribute to them remaining abstinent from alcohol use. This concludes today's episode. I would love to hear feedback on what you thought of the podcast. If you have any questions or comments, please visit www.conceptsinpsychiatry.com to contact me. As always, thank you for your continuing support of Concepts in Psychiatry. This show is hosted, recorded, and produced by myself, Dr. Sarah De Leon. Information on all reference materials used to produce this episode can be found by visiting www.conceptsinpsychiatry.com. Thank you.
If you enjoy this content, don't forget to like, comment, and subscribe. Share this video with someone who may need it. For more information, visit peoplewithalcoholism.com. Follow People with Alcoholism on Facebook, Twitter, YouTube, Instagram, and Pinterest for additional support and inspiration. Our blog is intended to inform and support you during alcohol recovery.